Welcome to episode 2 of Endoscopy Cafe, Expert Conversations. This webinar, just so everybody knows, will be about 1 hour in duration, and we're featuring 2 interventional endoscopy cases presented by senior fellows from UC San Diego and Mahidol University. And just so you know, this event is brought to you by 2 great organizations working in collaboration, the Association of Women Endoscopists and Women in Gastroenterology Network Asia Pacific. And you can find more information about this on our website, associationwomenendoscopists.com. And I'm going to have our panelists introduce themselves shortly, and the GI fellows will introduce themselves prior to the presentation. But first, I'm thrilled to introduce our 2 guest experts from across the globe, Dr. Amrita Sethi and Dr. Anthony Teo. Thank you both for being here. Amrita Sethi is a professor of medicine at Columbia University Irvine Medical Center in New York City, New York. She's the program director of their Advanced Endoscopy Fellowship and the director of Interventional Endoscopy. Dr. Anthony Teo, he's chairman of the WEO Research Subcommittee. He is a clinical associate professor, honorary and consultant honorary at the Chinese University of Hong Kong. He's vice president of the Hong Kong Hernia Society and vice president of the Asian Endoscopic Ultrasound Group. Thank you both so much for joining us tonight. We're hoping that this is just relaxing chit chat about 2 interesting cases. And grab your tea if you're across the globe and it's morning, or grab your glass of wine if you're joining us from the West Coast or East Coast of the US. Anyhow, thank you all for being here. And I'd like the panelist, Dr. Sonia Riker from Harbor UCLA, if you could introduce yourself. Let me introduce myself. I'm Dr.
Yes.
Mary Zakrinsky. I'm a therapeutic endoscopist at UC San Diego in San Diego, California. I'm also co-founder of the Association of Women Endoscopists. Thank you. Sonia.
My name is Sonia Riker. I'm an interventional endoscopist at Harbor UCLA and also co-founder of Association of Women Endoscopists.
Okay, that was fast. And Nanthali from Bangkok, Thailand. Oh, unmute yourself.
Oh, sorry. Hi, everyone. I'm Nantali Pauswasti. I'm from Bangkok, Thailand. I'm the current president of the Thai Association for GI Endoscopy, also a co-founder of Women in GI Asia Pacific. It's called WIGNAP, Women in GI Network Asia Pacific, and it's such a pleasure for me to be here.
Thank you so much for joining us. Thank you, everybody, for joining us. First up, I'd like to introduce briefly our senior and chief fellow from UC San Diego, Dr. Laurel Branch, and she'll be presenting us a complicated case of malignant biliary obstruction. Thank you, Laurel. You're on.
Thanks, Dr. Krinsky. Let me share my screen. For Endoscopy Cafe, we have an interesting case, an 83-year-old female who had a benign gastric tumor with a distal gastrectomy, has Billroth 1 anatomy in China 23 years ago. Came to our institution in June of 2022 with biliary obstruction, and she underwent EUS FNA for diagnosis and ERCP for biliary decompression at that time. She was determined to have unresectable pancreatic cancer and malignant biliary obstruction, and ultimately progressed to have gastric outlet obstruction. So that's kind of the 360 view of what happened, but just to take you through some of those procedures she had. So she had multiple biliary interventions. The first was at the time of diagnosis when she had her FNA of the pancreas head mass, and then ERCP with sphincterotomy and placement of a fully covered metal stent across her stricture. She came back a month later with cholangitis. ERCP showed occlusion of the bile duct stent secondary to debris, and she had another ERCP, removed the debris, replaced the covered metal stent with an uncovered stent. Had another episode of cholangitis with cleaning of the stent and placement of a new one. She made it a few more months until March of 2023 when she had increased LFTs. And this time she actually had concern for cholecystitis. ERCP with balloon extraction revealed a large amount of debris. There was noted angulation of the duodenum with some mild luminal narrowing, and we're unable to remove the fully covered metal stent. There were some attempts made to kind of pull the stent down further to ensure it wasn't blocking off the cystic duct, but she did well with antibiotics for treatment of her cholecystitis. Then a few months later,
I was going to stop you here
Sure.
because I was going to ask our guest experts, what do you think about this case where we've had recurrent obstruction in such a short period of time when we place this metal stent? How might you have approached it? And are there any techniques or approaches that you use to minimize this, or is this something you're seeing more recently? And I guess the devil's in the detail. You can see that originally it was a 5 centimeter fully covered stent, then it was a 60 millimeter fully covered stent, and then an 80 millimeter covered wall flux stent was placed. So I was just curious what your thoughts are about this. In my experience, usually the patients have the stents having patency rates much longer than this. So this was somewhat unusual.
You want to start, Anthony?
Yeah, Anthony, do you have any thoughts?
Sure. I think I probably would have approached the case pretty much similar. I think I don't know why, but in Asians, we do see more often. Might be because of somehow we do see a lot of primary bile duct stones in Asia. Probably when the patient had cholecystitis, we might have done something to the gallbladder because the stent is covering the cystic duct. And we know from literature about 20 to 30% of the patient would have a cholecystitis. So I might have performed a US guided gallbladder drainage in this instance, just to prevent it from coming back. But I probably wouldn't have changed to a uncovered biliary stent. I would just remove the debris and replace the covered metal stent with a covered stent instead of uncovered stent. Amrita?
Yeah, I don't have much to add. I think I agree. I think it's interesting that it was just a month later with the cholangitis. It does raise the question if there was a duct that was being jailed off that hadn't been, demonstrated in the first procedure. I also wouldn't have necessarily changed it to an uncovered. It's usually the other way around, I think, when we are dealing with placing covered and uncovered, at least for me, to deal with like tumor ingrowth and tissue overgrowth. And I agree with the cholecystitis question as well. Maybe placing double pigtails at the time of the July, or at least one stent through, just to see if that helped keep it a little bit more free of cholangitis, but otherwise probably similar.
Yeah, that is one of the strategies we've been using at times, is putting some pigtail stents in to try to keep it open. Anybody have any experience with ursodiol? The WD-40 of the bile duct, or theoretical? I think it's a flip of the
Yeah.
I don't think Urso would have helped that much, especially in malignant bile duct obstruction. I generally try Urso in primary or de novo CBD sludge, stuff like that, or even, a little bit of gallbladder sludge that I thought might have created a problem. But I think in this case it's different, so I don't think Urso would have helped or would have changed anything in this case,
I
really.
will say that I've been using it more so lately because these are frustrating cases, and URSO, the risk of URSO is relatively little. And anything that may help in these patients who you're just bringing back so often. But I don't think there's any evidence either way.
Sonia, any thoughts?
Do you think there is a component of this having whether that's covered or uncovered metal stent that is contributing to that sort of sludge formation? Has it been, in your view, has it been a little bit moved towards using plastic stents, maybe combination with radiofrequency ablation as an alternative? And if we are intervening on her anyway, every 3 or 4 months as it is, or sooner, could that, because at this point, I also don't know what the right answer is, but in your mind, I seem to be doing more plastic stent and RFA. I'm not necessarily sure that that's the way to go.
It's funny you say that. I have a very similar case actually that it's like nothing really quite works, and he's been going between metals and then double pigtails with RFA and metals, and what's great is that he is surviving, and that's one of the issues I think that we deal with now, is that the survival is so much better than we originally thought when these stents were created. So I think that's a very reasonable strategy to see, especially if a patient, I don't know if this patient was on treatment or not, but if patients are doing well and it's just stent maintenance, can you actually, just keep them with the double pigs, and you don't have to necessarily bring them back. I don't think every 6 to 8 weeks or even 3 months, because the double pigs, as long as if you have multiple in, kind of achieve the same thing that the fully covered does, I think.
Yeah, those are all good points. Thank you, guys. Laurel, do you want to continue on?
Sure. Yeah, she had one last ERCP in June of 2023. This time they were unable to traverse with the duodenoscope, actually used a 1T endoscope with a cap, cleared the stent again, and then did place a double pigtail through the metal stent, placed it low enough that it could also kind of help protect the lateral wall of the duodenum from ulceration as things were changing, from kind of getting more difficult with the angle and the duodenum. So 1 year after her original diagnosis, she came to the ER and she had nausea, vomiting, imaging here seen on her CT scan with concern for gastric outlet obstruction. And at that time, the decision was kind of going back and forth about what would we like to do for treatment of her gastric outlet obstruction. Ultimately decided with placing a duodenal stent, did the endoscopy, cleared her stomach, confirmed that she had a partial gastric outlet obstruction, placed 22/90 duodenal stent.
So I guess this is where the decision was whether or not to do an EUS Gastro J, or if this is something that we should just, it's simple, it's straightforward, just place an enteral stent. And one of the concerns was her gastric surgery. How would you approach this? Amrita, you can be up first.
Well, I think I'd ask, a few questions like, what is her life expectancy or prognosis? I think most guidelines, society guidelines these days are suggesting that, if it's less than 2 months, then can go ahead with an enteral stent. But if it's greater than that, then consider a GJ. And the other is that I think the anatomy does alter things a little bit. There's, well, I don't know. I mean, it depends with the pylorus. You don't usually get tissue and growth over the pylorus, but here, where if it's angulation as opposed to tumor obstruction, you may not get as much relief from the stent. And I think another issue to think about is the fact that she's having recurrent biliary issues. And that stent still needs to be managed in some way. The biliary stent still needs to be managed. And so doing something where you can also do like an EUS guided hepatogastrostomy and just kind of, or the EUS guided GJ allows you to gain access to the papilla from the other direction, and potentially, you know, do something with that stent, even if it's just to pull it out, and then do an EUS hepatogastro, sorry.
Yeah. So one of the issues is that we did feel from talking with oncologists that our life expectancy was 2 to 3 months. And so we did feel that it was reasonable to do the enteral stent placement. It was at a time when so at our institution, we manage these cases. Whoever's on call really just gets these cases. It just rotates through 6 interventional endoscopists. And the interventional endoscopist who was on at the time, me, at that point, I didn't have any experience with EUS guided gastro J. And so I was a little bit gun shy about doing, for all the reasons. I thought maybe it would be better to approach it that way. And since she had a Billroth one, maybe it would have been reasonable to do it, to look with the US, see if I could see the jejunum. And I even called one of our friendly experts from WIE, who's a friend, and asked what their take was. And they kind of agreed that maybe this wasn't the best case for it to be my first. I mean, I've done US directed there. I've done every other one, but I hadn't embarked on this for some reason. So the decision was, given her predicted short lifespan, that I would just go ahead, but I was very concerned about that bile duct stent as well. And Laurel,
Yeah.
any other thoughts, Anthony and Amrita and Nanthali?
I'll just say really quickly, Mary Lee, you brought up a really good point. If you, again, ESGE guidelines have come out in the past year and 2 years, I guess, you know, specifically on EUS guided therapies. And when they talk about anything interventional EUS, the first and foremost thing is you have to first see what your local expertise is. And we know from papers on training and adverse events about procedures like this that there is a learning curve. So I think that was an excellent decision, that if you didn't have supervision and it was a, you know, on-call case, that this was probably not the first one to be doing it on. And it's absolutely reasonable to have gone with, you know, what your expertise is in that moment. So I'll just say that.
Okay. Thank you. I won't get into the technical aspects of it, but as you mentioned a really good point, that it was angulated. It was a little bit tough, and I wanted to make sure I aligned the stent properly. So I used some clips, you know, to give me some fluoroscopic guidance to make sure I was hitting the proper landmarks. But anyhow, any other thoughts, Anthony?
I would have assessed the feasibility of doing a GJ on the CT. I think the presence of Billroth 1 doesn't exclude it from being possible technically. But then now that the duodenal stent is there, and if the patient does have a recurrent obstruction, then another ERCP may or may not be possible. So in that situation, you might be looking at a US biliary drainage procedure. So that's something to keep in mind.
And another thing to be just perfectly critical of myself, because I think we always have to evaluate what decisions we make in the moment, that, you know, potentially gastric outlet obstruction isn't an emergency. And this perhaps could have waited a day or two, where I could have collaborated with one of my colleagues and done the GJ. I could have looked at the CT scan and seen maybe it was feasible. And with ultrasound, I don't think I'd want to put him through 2 procedures, but maybe we could have waited over the weekend till Monday to do that.
Yeah,
Anthony,
definitely.
what will you be looking on the CT scan to determine if that was a good candidate or not for a US guided? gastric.
Yeah, basically the distance between the DJ and the stomach. So the presence of a GOO means that probably the patient would have a distended stomach, and I would see how far it is from the DJ.
I think actually in the image that you showed in the presentation, there's some nice images there of the stomach approximating the small bowel, if I remember.
Go back a little, like right there.
Yeah, possible. I probably would have to go through my images.
Yeah. Giant stomach. Okay.
Okay. So she had her duodenal stent placed and then developed recurrent biliary obstruction. She then underwent left-sided external biliary drain placement with interventional radiology. They internalized their external biliary drain, and 1 day later, she developed recurrent symptoms of gastric outlet obstruction. She underwent endoscopy where she was found to have a large amount of food in the stomach. The duodenal stent was patent and was able to be traversed with the endoscope, but the IR catheter was noted to be occupying at least part of the lumen through the stent. She did okay after that procedure with just kind of monitoring, considering it to be a partial obstruction. But 1 month later, she still was having trouble with tolerating oral intake and did decide to pursue the endoscopic gastrojejunostomy. So we wanted to talk a little bit about our method, how we did the procedure here was first, the endoscopy, noting the food in the stomach that was cleared out, some mild resistance in the stent around the IR drain, but we're able to pass a wire, and then a nasobiliary drain. Went down next with the linear EUS to evaluate the jejunal limb, place some contrast through the nasobiliary drain, which you can see in that top picture, as well as a liter of methylene blue tinged saline to help distend the lumen of that jejunum that we were seeing on EUS. Found a good window, confirmed with Doppler, and then did the 20 millimeter hot Axios to enter the jejunal limb. No problems after that, and a large amount of the blue tinged fluid came out of the jejunum through the Axios and into the stomach.
One of our attendees has a question that's reasonable right now. It's that when you're considering this approach and the small bowel looks further from the stomach, how do you make a decision on if you are able to do this technique, or what size what size lumen opposing stent would you use, or would you consider just using a fully covered enteral stent? How do you make the decision of what stent you use for this procedure? Anthony, you're up.
Yeah, I think in general principle, when you do a GJ, the most feared adverse events would be a misdeployment. So naturally you would try to select the bowel that is closest to the stomach wall. Usually this is like not even 1 centimeter, it's just be a few millimeters or just adjacent to the stomach. So if you see a small bowel more than 1 centimeter or even to like 15 millimeters, then you need to seriously think about the risk of misdeployment, because once you puncture, the bowel might move away further, and you may not even be able to enter the small bowel, or you might just touch the small bowel and not being able to insert the delivery system. So I think it's a call for the operator on site. So you need to decide, at least from experience, whether you've seen such a situation and how confident you are, because as with all of these EUS procedures, once you start, you can't stop. And if you decide it's not, a good target, then you can always have a second option of going back to the duodenal stent. So yeah, you need to assess on site.
Anthony, you you use for your Gastro J, at least in publications, you have one that just came out in Lancet. You're using the double balloon occluder to stabilize the small bowel. Is that right?
Well, for the study, yes. But
Not
nowadays
for
we just
everyday
mostly
use. Not for
we're
everyday
doing
use.
mostly freehand.
Okay.
We're doing mostly freehand now. Yeah. But if you have the double balloon occluder or even the newer double balloon from Yan Chan, that's a really stable platform. So it's almost 100% foolproof. Definitely good for a beginner to use that balloon. But in those situations, it's a very stable situation. So you can really take your time to puncture and deploy.
Yeah, I think it's a good idea to, again, while you're getting through that learning curve, always use the same dedicated technique so you can really understand, what the challenges are that you're facing and how you overcome them, as opposed to switching back and forth between techniques. It's probably a good way to get past that curve.
What is the curve for us average people? What would be the curve?
Well,
You
based
think?
on Moeen's publication, Moeen
Right.
Kashab's publication, I think the curve was
15, I think, something
No, I
like
think
that.
it was
13
20. I think it was 20.
Right.
And I think it was 30 for mastery,
Right.
maybe even 40, but I think at least 20 based on that paper.
Yeah, and I think
Anthony,
most complications were in the first 15 or 13 or something like that.
Anthony, in your center, how many people are doing US guided therapies?
Depends on what kind of therapies. I think all our fellows starting to do some. I think Shannon and Raymond, they are the two persons that are doing most of the advanced stuff. So GJ, beta drainage, and so on. So I think for each fellow or even the consultant, their pace is a little bit different. Some may want to do more. Some may want to do just PFCs. So yeah, so just us three doing most of the complex ones.
Can I
Any
ask
other?
a question about this case?
Sure.
Was a EUS guided hepatico-gastro considered as an alternative to the percutaneous strain?
No, we didn't. No, but I think that's a good point. That's something, again, I think, yeah, that not many of us have embarked on. We have one of our group who's done a few of those cases, but not a lot of those. But I think that would have been a valid approach. And also given, I mean, if you look at the prior images, had a very marked dilation of the biliary tree. So technically, it potentially would have been quite feasible. And according to, you could comment on your experience, but from talking to other experts and reading the papers, it does seem like technically not as challenging as some of the GJs from the beginning approach, from what I've heard and seen and read.
Yeah, I mean, I'd love to get Anthony's take on it because he's probably done far more than any of us, but especially when it's dilated like that. And I think that's the benefit that US guided offers, particularly in a case like this, is trying to avoid having to have that percutaneous, especially since you have, you do have relief of the gastric outlet obstruction. So it's not like you would just be draining into the stomach, but then still have an obstruction. I might have even considered it, or I will say that I have considered it in cases that are refractory, even in patients who've, had long survival, and it's not necessarily a question of their malignancy that's causing the recurrent episodes of cholangitis, is actually to consider if you have the appropriate size duct and access, and there's no other intrahepatic strictures is to consider just a fresh anastomosis in order to help relieve the recurrent cholangitis.
Yeah, I probably would have done an HGS a bit earlier. But then if the patient still has the recurrent obstruction, then I guess percutaneous is not a bad option because it's a bit easier to manage. If the patient has recurrent obstruction, you can just flush the PDBD and not have a repeat endoscopic procedure. So
If I could share a little bit of my experience on the EUS GJ, especially when you start doing the procedure. A lot of us do not have the double balloon occluder. So what I've been using, especially when I started doing it, was that I use a single balloon occluder, which is an aortic balloon. I use that to help instilling water because I feel like when we start doing the procedure, for the freehand technique, you have to be very fast in all the steps because the water is going to distend the small bowel loop for a certain period of time. And if you kind of hesitate with each step, sometimes the water doesn't stay and doesn't distend that small bowel loop long enough for you to complete the procedure. So I use an aortic balloon to just help keeping the water to distend the small bowel loop until I complete the procedure. And I think once you get more familiar with the entire procedure, then you can, proceed with the freehand technique. At least that's one of the things that we've been doing or practicing. Yeah. And the other thing is that a lot of us are kind of afraid of doing EUS HGS in patients who had prior history of gastric surgeries. I think a lot of us are concerned about that. But Anthony can comment more about this. I think it's just a matter of how much stomach is left and whether or not you have enough space. But I just don't know in patients with prior gastric surgeries, do they have more of adhesions or anything, Anthony, between the stomach and the liver that might prevent us from doing EUS and GS?
I think with a B1 or B2, actually, after surgery, there would be definitely some adhesions. And in any event, it might actually help with the adhesion of the stomach to the liver. So after when you're performing HGS, I think the stomach should be closer to the liver, and the chances of a leak or a dislodgement would be lower in those situations.
And Nathalie, that's incredibly creative way to do it. And I think another thing that it helps with is that, if a liter is actually quite a bit of fluid, and like you said, if you take a lot of time, a lot of that fluid can reach the colon by then. And if you're using contrast or just relying on your EUS view, some people I know will put an EUS needle down and confirm. I didn't see if that was done or not, to confirm, that you're getting back the blue fluid, and you may inadvertently be in the colon, like going into the colon and could deploy it in the colon. So I think having that type of a balloon and the double balloon obviously helps prevent migration of the water to colon.
Well, thank you all for this. I think Laurel's about to wrap up and we can move on to our next case.
Yes, so this is kind of the conclusion. After the procedure, she really did very well, had significant improvement in her symptoms, followed up with all her providers, able to eat without nausea or vomiting, gained some weight. She did have an intermittent episode of recurrent symptoms and underwent endoscopy where it showed that the proximal flange had kind of gone into the GJ lumen, but everything was still patent. And so this was not intervened upon, kind of left as is. She continued to do well from that standpoint, but unfortunately had progression of her disease and was enrolled in hospice several months later.
Can I ask you just a quick question? After placement of Gaster J, let's say a month or two later or at any point, do you routinely remove the aluminum opposing metal stent, or you leave it as is after the fistula is formed?
I leave it. Anthony?
Yeah, of course, same. I leave it. The obstruction is still there, so.
In this case, you can see it seemed to migrate a little bit into the fistulous tract. How would you approach that? And is this something that you see commonly? This was a 20 millimeter, 20 by 10.
I mean, it depends if that's causing its own form of obstruction. So I would, consider dilating it and or placing another stent through there, maybe a 15 saddle length or even a short esophageal if necessary. But yeah, I would only really treat it if it was acting like an obstruction.
Yeah, same. So if there's obstruction, then definitely you can do a stent depending on the length. I'm not sure why this stent is moving out. Usually there's this sort of like a buried bumper situation if there's some kind of pulling force that are pulling the two organs apart. I'm not sure if the small bowel is a little bit too far from the stomach initially. But yes, yeah. If it's causing symptoms, then you can definitely do a stem instant.
Yeah, sometimes I don't know if did she develop ascites in the interim, because that could sometimes drive apart the small bowel from the stomach.
Okay, I think it's
Speaking of, I'm sorry.
oh,
I
go
was
ahead.
gonna say, yeah, speaking of removing the stent, my experience is that after I removed the stent, and this is in benign cases, after I remove the stent, 100% of the cases they come back with anastomotic stricture. So for benign cases, after we remove the stent, we have to bring the patient back to continue to do anastomotic dilation to keep the anastomosis patent. And apparently the endoscopically created anastomosis doesn't work as well as surgically created anastomosis, I guess, because in surgery, I believe the anastomosis is very big and wide. For ours, it's smaller, so once we remove the stent, the anastomosis is just closed off. So yeah, so especially in this patient with malignant obstruction, I don't think we should remove the stent at all. Yeah.
Well, thank you very much, Laurel, for your succinct presentation and everyone for their comments. I think that John, you're up next with your presentation. If you could introduce yourself, John, that would be great.
Okay, thank you, everyone. I will share my screen. Okay, hello, everyone. My name is Kajonwit Rakharuthai. I'm an advanced endoscopic fellow from Thailand. I would like to present the second case here. It's a 61-year-old man with the underlying disease of chronic hepatitis C infection. He presented with the chronic intermittent non-specific epigastric pain for 2 years. He denied the continuous symptom or jaundice. His physical examination was unremarkable. The initial laboratory was normal. The liver test is shown here. He was scheduled for the ultrasound upper abdomen, which showed mild intrahepatic duct dilatation with the ill-defined hypericonicity along the periductal system. So the cross-sectional imaging was done. Here is the CT of this patient. So the CT shows the multifocal dilatation of bilateral intrahepatic duct. The CBD seems normal without CBD stone. The MRI was further scheduled for evaluating the cause of bile duct dilatation of this patient. Here's the MRI MRCP. The MRI here also shown the bilateral intraepithelial duct dilatation with multifocal like stricture. There's the intermediate T2 hyperintensity without restriction noted at the periductal area, which could be soft tissue or fibrosis. The focal enlargement was noted at segment 2 and segment 3 with the very small, about less than 1 centimeter diameter. No CBD stone or intrahepatic stone was noted here. Now we are thinking of a patient could have the sclerosing cholangiopathy. So the further investigation was sent with anti-HIV IgG4 level and the tumor marker was in normal limit. So I'd like to ask you, what is your impression of this patient and what you the plan for the further investigation?
So I guess the imaging findings are suggesting this patient may have a PSC with a deranged liver function. Probably he or she needs a ERCP. I'm not sure if there's any Hyler shadow because I just on going through the MRI, I just saw something in the MRI, but it was going through quite fast, so I'm not 100% sure. But from the report, there's definitely multi-segment strictures. So if this is a case of PSC in general, it is suggested to dilate these strictures and not put in a stent. So Amrita?
Yeah, the only thing I would add is maybe an EUS as well, to look for any, as you said, hilar mass or lymphadenopathy that could explain the intraductal. Certainly not for biopsy if you saw a mass, but I think that might be another thing to do.
And that might be a silly question, but there is quite a bit intrahepatic biliary dilation. Does it give you a little bit of pause with the sclerosing cholangitis diagnosis, having that? Because normally it's sort of don't have as much of intrahepatic biliary dilation with that.
Yeah. Yeah, I think this is not necessarily like the classic beaded appearance of
Right.
a PSC. And as you mentioned, usually those ducts are actually quite thin with strictures, or aren't necessarily this kind of dilated. Maybe intrahepatic cholelithiasis could be another with secondary cirrhosis or biliary cirrhosis, or yeah.
What your next steps would be? Where would
Well,
you go from there?
I think an ERCP, as Anthony mentioned, is reasonable. Like I said, I might throw an EUS on there as well, just to, look for anything going on at the hilum that's obvious. Look at the duct wall if there's any thickening or intraductal masses that you might be seen, or lymphadenopathy.
Cholangioscopy?
Any role, yeah.
Yeah, that I feel like that's an assumption with any of ERCP. Yeah, yes.
That's
love to
in
do
Amrita's ERCP
cholangioscopy.
package. Cholangioscopy.
All patients get consented for it.
Yeah, I would agree. Initially, when I first saw the MRCP and CT scan, the CT scan images, I also thought about PSC as well. But then if you look at some areas in the right lobe, the duct looks like, it's the dilation there in the intrahepatic ducts. I think is a bit too much more than I have seen in PSC. So so I think it could be PSC, but if it is PSC, then it might be something else, like Amrita mentioned. Yeah.
Or even, there are those cystic areas, cystic dilations as well.
Yeah.
Corolli's as a possibility, although you still shouldn't see that kind of diffuse intrahepatic dilation.
Right. So yeah, so John, what did you do next?
So the patient visit the surgeon who was concerned about the intrahepatic duct cholangiocarcinoma, which has a high incidence rate in Thailand, over 20 to 40 per 100,000 patients. And cholangiocarcinoma can cause like multifocal stricture like this, and it is also reported in PSC as well. So ERCP and cholangioscopy was replaced in the same sessions. So here's the ERCP. The ampulla looks normal. And on the first picture, we calculate on the right side of the intrahepatic duct, which show quite normal intrahepatic duct lumen size, and there's some irregularity on the duct wall. On the left side, we show the dilated of the left intrahepatic duct, with much irregularity was seen here. Really avoid the over-injection of the contrast, given that post-ERCP cholangitis was concerned. So here's all the ERCP picture. So we move on to the cholangioscopy here. Now we are in the left intrahepatic duct, which show the circumferential lesion of the papillary growth here. The lesion is seen along the left intrahepatic duct up to the second order, from down to the left main intrahepatic duct. And when we slowly pull down the scope back to the CBD wall appear to be here, like is from here is in the left main intrahepatic duct. And here we fall off back to the CBD here. The walls look quite normal. Unfortunately, we couldn't put the scope back to evaluate the right intrahepatic duct. So here from ERCP and cholangioscopy, what do you think the diagnosis is, and how would you plan for the patient management?
So, Amrita, what would you do next in this case?
I would definitely biopsy this. Beautiful images, by the way. What a beautiful exam. I would biopsy both the papillary lesions as well as the normal tissue, and you know, temporarily stent, but it does look like some type of papillomatosis. I don't know. I'm not too familiar with. I certainly haven't seen quite a lot of that. I don't know if that can form secondary to stone disease, because he did have stone material up in the intrahepatics, or even some form of infectious cholangiopathy. Anthony?
Yeah, definitely biopsy to rule out cancer. But from the images, I'm not sure. It's more like a benign papillomatosis kind of thing, rather than like cholangio. And in this situation, if there is obstruction, obviously, we might consider a plastic stent instead of a metal stent, because I think these patients always come back with recurrent obstructions, and placing a metal stent might complicate the management.
So on this, John, you saw a clear demarcation at the common bile duct as you pulled back. What about proximally? Did you see you were only able to go into was it the left side, you said? Left hepatic?
Yes, most of the cholangioscopy picture here is in left intrahepatic duct.
And did you take any cholangioscopic guided biopsies or during this case?
Yes, we do the biopsy of the lesion here in the left duct.
Yeah, let me ask you guys one question. If we, you know, the fact that we couldn't access right intrahepatic duct, but we got the cholangiogram, if you remember, we injected the contrast below the highlight level. And we were able to feel the initial image. We were able to feel, I believe, right posterior segment. And the ducts didn't look too bad. I can't remember if we had attempted to enter right intrahepatic duct and we couldn't, or we didn't even try at all. I can't remember that, but I would have thought that I must have had tried to enter right intrahepatic duct, but I couldn't for some reason. So then my concern was that, well, we know for sure the disease is involved left intrahepatic ducts, but we don't know the extent of the right intrahepatic duct. But if you look at the MRCP, you see some abnormalities in the right ducts as well. So I remember this patient was sent to us by a surgeon who thought of cholangiocarcinoma. And obviously, I would agree with Anthony that what we're seeing on the cholangioscopy, it didn't appear to be cholangiocarcinoma, but at least papillomatosis type thing. And we didn't really, at that point, didn't really quite know the malignant potential, like how many percent of these patients would turn to have cholangiocarcinoma. So the question is that the fact that we couldn't access right intrahepatic duct, would that I guess, would you have attempted to enter as much as you could, or you would just say, okay, that's it. We get the diagnosis from this. I guess I just don't know how much we should try.
Specifically with the cholangioscope?
What?
Specifically with the cholangioscope?
Yeah.
Yeah, I don't know that, I mean, the ducts really weren't that dilated, to be able to fit the cholangioscope up there, even had you been able to. And I guess the other question is like, what are the potential management options or surgical options for this patient? Or do they even need a surgical option? Or would you just be planning to manage long-term with stenting, which I think is probably not ideal, but because if it's surgical, then I think that the surgeons probably would, Anthony can tell us, but would benefit from knowing if there's some involvement. But I think the malignant potential is so low that even if there was some disease involvement of the right side, even if you did a left hepatectomy or something and left the right in place, I don't know that there'd be that high risk of malignancy. I don't know, Anthony, do you have more experience with that?
I think the extent of the disease is quite diffuse, so it's probably surgery would be out of question, I think. But yeah, it also depends on whether the right side's affected or not. From gut feeling, I think both sides are probably affected. But yeah, so I guess we just need to see the biopsy results first and decide.
You could
Yeah.
also brush, right? I mean, it's low yield, but if there's enough involvement, then you might see it on the brushing, or just specifically the right side. Because I think you can.
From the right. Yeah.
Yeah.
Brushing from the right, biopsy from this from the left.
Or in some cases, you could do the wire guided biopsy forceps if you have access to those, this really small ones that fit over the wire. But I don't think it's as critical.
Okay.
And how often would you use, just for our fellows in the group that are watching, how often would you use a cholangioscope to help guide access with the wire visually if you're having trouble getting into one system versus the other? Do you ever attempt it that way? Do you find it helpful?
I feel like that's a loaded question for me. I do it often, actually, especially if I know I filled the duct and I'm having difficulty getting a wire up there and I want to make sure I'm decompressing. I find it very helpful, using 2025s so that you can actually cannulate two different ducts and exchange it out. I think it saves a lot of time, a lot of fluoro exposure.
Yeah.
And
John, did you biopsy this? Did you I guess you did. We did. Yeah. You can tell them the biopsy results.
So we place a plastic stent in this case and do the biopsy. Pathological report show the some fragment of papillomatous growth of biliary mucosa without dysplasia or malignancy. So we diagnose this patient as a biliary papillomatosis. So the multidisciplinary was discussed with the surgeon and the patient, and the plan for the left hepatectomy as the lesion is mostly in the left intrahepatic duct. And after that, we will follow the imaging for surveillance the right duct disease.
Is there any role first to, I assume you stented the system, but just to roll for stenting first before you go directly to hepatectomy to see if that will, alleviate the patient's symptoms, because you potentially have diffuse disease. So the question would be, what Anthony and Amrita, what do you think about kind of a stepwise approach to management versus jumping right to left hepatectomy and something that is most likely a benign disease?
You'd have to remind me, but this patient mostly presented with abnormal imaging and elevated LFTs, right? Which weren't even too bad. Not necessarily cholangitis or recurrent cholangitis. So in terms of which symptoms you're trying to relieve, I think with this kind of diffuse disease, the chance of improving the LFTs, which again, weren't that high, are going to be low. And you definitely don't want to leave, like PSC, you don't want to leave stents in long term. It just increases their risk for cholangitis. And the disease is so diffuse. And if you think about things like Whipple, IPMN in the pancreas, papillomatosis, decompression doesn't really help in those situations either. So I'm not sure that in this case there would have been a need except for immediately post ERCP to make sure you have drainage of anything that you put in.
Natalie, you probably see more of this disease than we do. In your experience, what is the risk of cancer in these lesions?
Oh, John actually has that on his next slide.
Okay, I'll patiently wait. I'll patiently wait.
So yeah, I can I can let John give you a very quick review of papillomatosis, but before he goes there, since we are approaching our final 5 minutes of the session, I just want to emphasize what Anthony and Amrita had just mentioned about placing a stent in this kind of situation. So we were debating about whether or not we should put a stent in this case, because he didn't really have any symptoms when he presented, and his LFTs were completely normal on presentation. It's just that the surgeon was concerned about cholangiocarcinoma because of the high prevalence of that disease in our country in intrahepatic duct stricture. So, but after debating, we decided to put a stent in. We placed a stent in the left intrahepatic duct because we thought the main stricture was there. And I believe 3 weeks later, the patient presented back with fever and mild jaundice with abnormal LFTs, basically post-ERCP cholangitis, which was delayed a little bit. And on follow-up imaging by ultrasound, he developed liver abscess in the right intrahepatic ducts area where we injected contrast. So that's one of the things that I think it's a good teaching point. We didn't put it here because, the case would have been too long. He was treated with antibiotics, didn't need any drainage or anything. He responded to the antibiotics. But the key point is that, this type of patients, they are at risk of having post-procedural cholangitis plus minus liver abscess. So I think that it's very crucial to decide whether or not a stent is needed. In this case, we thought we should put it. I don't know if the results would have been different whether placing or not placing a stent, because the abscess occurred in the right side of the liver, which was the undrained segment after the procedure anyway. Okay. Yeah, so that's one of the teaching point. And then I'll let John talk more about papillomatosis here.
So I have a short review about the biliary papillomatosis. It was a rare disease with the multiple adenomas arriving with variable distribution and extent in the biliary tree. It is benign but with high malignant potential, with the reported of the 40 to 80% malignant transformation. It is predominant in male with the mean age of 50 to 70 years old, which is compatible with our patients. It can be divided into groups of the mucin producing with non-mucin producing type. The presentation is very range from asymptomatic to acute or chronic biliary obstruction. The investigation, the imaging will show bile duct dilatation or thickening of bile duct wall, or you can see the intraluminal mass. But this radiological imaging is low sensitivity and specificity and cannot differentiate between the benign and malignant disease. So cholangioscopy increases the accuracy of diagnosis, can more characterize the malignancy, and can do the target biopsy. The management, there is no consensus or guideline of this disease. We divide it into the localized disease and diffuse disease. For localized disease, there's controversial for optimal therapeutic strategy. We can do local ablation or radical surgical resection or liver transplants. The reported case for the surgical resection report the 80% of 5-year survival. For the diffuse disease, liver transplantation is a short but it reports very poor prognosis. In an operable case, the biliary drainage with clinical and radiological follow-up is considered. So thank you for your attention. Yes.
Well, any comments from Dr. Teo and Dr. Sethi? Any last comments? I'd like to thank both of you for being wonderful expert witnesses. I mean, sorry, I'm thinking I'm going experts.
On trial.
I don't know, I've been long trial. Experts for our episode 2 of Endoscopy Cafe. Thank you, Dr. Sethi and Dr. Teo. I'd like to also thank our fellows for presenting these excellent cases that kind of demonstrate not only one, a rare disease with many technical challenges. We could go on and discuss all the semantics. There's so many teaching points in the case that Laurel presented with many different twists and turns to that scenario of a patient with what comes as a common problem of malignant biliary obstruction and all the things downstream that can go awry. So I'd like to thank you both, and I'd like to thank my co-conspirators, Dr. Paswadi and Nanthali, and Dr. Riker, Sonia. Thank you so much for being a part of this excellent program. And I just want to thank our sponsors. I think Christian, who is I want to thank Triodyssey, who puts this show together for us every time. He can put up the last slide. And any other comments, Dr. Riker? Sonia?
We're very, very grateful for participating. Thank you.
Thank you so much for having us. It was really great.
Well, now we can relax and have our wine and
Nanthali, you're gonna go. You guys are gonna go to work, right?
Coffee and tea and get to work.
Yeah, well, Anthony and I cannot drink wine right now because we're gonna start
Just
working.
delay, just delay a little bit.
Coffee,
Just
coffee.
delay a little bit. Just delay a little bit. But Nanthali, we're keep on going, I think, right?
Yeah, very nice. Thanks, Amrita and Anthony.
And I'd like to
Thank you so much.
and our audience. Thank you for participating. And our next Endoscopy Cafe, look out for the next date, probably June, July. Keep a watch of our website, associationwomenendoscopists.com. Thank you. And I'd like to thank our sponsors too. Thank you.
Thank you.
Thank you.
Good night, guys.
Thank you.
Bye,
Good night.
everybody.
Bye.